National health insurance has become, well, the hottest topic on many of the social media boards here on BizNews as well. And pretty much one-way traffic that we've been seeing from the private sector. But today, we're going to be talking to Dr. Nicholas Crisp. He is the man given the responsibility by government to implement national health insurance, or at least to explain to us why it's so important. He's the Deputy Director General at the Department of Health. Nicholas, LinkedIn tells all, and it tells a lot about your story, one of working in the public sector, then having a startup which was sold to EOH. I guess you got your own stories about what happened at EOH during that time. But having retired after that and after working there for a little while, you were then pulled back into government in this most controversial of jobs, I'm sure. Any regrets?
No, Alec. I've been working in the public service, as you said, for 40 years. Well, next year's 40 years in this country and 6 other African countries. And every job that I've done has been difficult, right from my internship until now. And I've always been told, you can't do it. And well, so far so good. We've been able to do the things that I've been involved in, including my job as the first head of department in what is now Limpopo province during the transition out of the Homeland Times into the present, and setting up the National Health Laboratory Service and a number of other things here and in Nigeria where things have never been easy. So no, I'm okay. It's a big challenge, but if we don't fix the health system, we're really going to be in even bigger trouble.
I guess nobody will argue with that we have a health system that is not delivering the outcomes that we should have. Where the argument starts is the people in the private sector saying, but have public-private partnership, work together, and we can fix this thing together, rather than implementing, as the National Health or the NHI Bill proposes, the end of private sector involvement. So just help us through there. What is the intention of all of this? Because the outcome cannot be doubted. We all want better health in South Africa.
So there's no exclusion of the private sector in the National Health Insurance Bill. And there's no such thing as the private sector. There's a segmented private players in the healthcare space. And so if you look carefully, you will see that the bill talks about the accreditation and contracting of every single private provider of health services, whether that's an independent single GP, whether it's a pharmacy, whether it's an optometrist, or whether it's a really big hospital. It doesn't matter. We need to contract everybody. So in the provider space, there's no question the private sector are critical players in that space. In the second space, around product procurement, it's the private sector that manufactures, imports, distributes, and manages the logistics of the pharmaceuticals and other health products that we use. And we work well with them for the most part. Every now and again, we'll differ over prices, but pretty much that is an entrenched space. And we don't anticipate that changing much either. We would like to get better prices over time. And you can only do that if you can give market certainty and you can get bigger volumes. So that's the second part where the private sector is very much an entrenched player in the health system. The one where the debate is and where you get the fight and where we are seeing the complaints coming from is around the way the funding will work. So we have medical schemes, we have insurance companies, and we have out-of-pocket payment, who currently are the financing mechanisms for about 8.5 to 9 million people in the country. The bulk of those 8.9 million people are purchasing some form of, we call them medical aids in this country. There's a small number that purchase insurance products from insurance providers who are not medical schemes. So in that medical scheme space, some people have the money and are able to purchase what we call comprehensive care. Others, it's about 22% to 25% at the moment, purchase what are called hospital plans, and there are a range of products in between those. And the challenge, of course, is that if you are not on a comprehensive plan, and in fact, even if you are on a comprehensive plan, you may have certain exclusions to what you're able to claim. But certainly if you're on a hospital plan, you have to pay out of pocket for all your primary health care. So what it does is it forces perverse incentives to admit people to hospital for things that don't need to be there. And it's a perverse incentive to seek specialist care when you need a general practitioner to be looking after you. And we feel that the general practitioners are the most neglected part of the whole health system. So there are structural issues around how we purchase our healthcare that are not working in both the public and the private sector. What unfortunately the concentration of the media has been is on the private sector. In fact, the vast bulk of what is in the NHI Bill is a restructuring of the public sector. So we have a big frustration that we have 10 different health departments, all funded separately through different funding streams, and they are pretty much autonomous and fairly independent in the way that they run their services. And in some provinces, they don't even control their capital works budgets. And in one or two, they don't even control their human resources appointments in the health department. Now, that's a big frustration for us because it's we in the national department and our minister who get a hiding in public every time there's something that goes wrong. Now, in the National Health Insurance Bill, the section prior to Section 33, which is the one that's attracting all the flack in the private sector, Section 32 removes the functions from the provinces and centralizes it to the national sphere of government and allows the minister to delegate back only the provider functions. And that allows the centralization of the current public budget, the 265 billion that's currently in the public budget. The bulk of that is in the 9 provinces. So it's a realignment of functions and a realignment of the way that services will be purchased that is causing greatest anxiety.
Okay, I get it now. There is a move towards centralization in one, if you like, ideology in the country, and there's a move towards devolution in another ideology in the country. And I guess this is causing tension because it's very much centralization. Am I reading that right?
Yeah, so Alec, what it's about is centralizing the funding, but decentralizing the provision. So there are also clauses in the bill that say that the hospitals must be autonomous entities. So that's the big irritation, and you will hear it frequently in the public space and on the social media groups that why don't we just let the managers get on with running Charlotte and Sheke Hospital? Well, that will become law when the National Health Insurance Bill is passed. They must get autonomy. And there's a provision in the current Health Act where the minister, the national minister, is supposed to appoint the boards of these hospitals. But some years back, there was a decision taken to allow the provinces, the MECs of the provinces, to appoint the boards of the big, especially the big hospitals. Now that the reversal of forcing these hospitals into an environment that's more like you would run a private hospital, with their own control of their own budgets, their own human resources, their own procurement, the service developments, and so forth, is what is now provided for in the bill. And the same goes for the primary healthcare environment, where the intention is that you try to decentralize out of the provincial governments into the 52 districts more of the planning, closer to the people. And the actual delivery is designed as an integration of what we call multidisciplinary teams in what we call the primary healthcare or contracting unit space. So, I think that centralizing the money so that you can see it all in one place, I guess you could look at it a bit like the government employee pension fund being run by the PIC. It manages trillions of rands worth of money centrally, where you're able to get real economies of scale and you're able to do things in certain ways you can't do if you decentralize that into many funds. It's the same idea. You can get a monopsony, and using that monopsony, you can get far better prices and far better distribution. And one of the central reasons why this is the route that's chosen in this country is that we are the most unequal society in the world, and we are not moving towards equity. We were moving away from equity, even in the public service, where those who have got more and started off with more tend to have more and more and more. instead of using what we call strategic purchasing to get a better distribution of access to services. So there's some centralization, but there's a lot of decentralization.
The other criticisms relate to the inability of the public sector to manage these assets properly, and you've just said how important that's going to be. Cadre deployment being a big issue, and it's rife throughout the country. And I guess the public is throwing their hands up and saying, here is yet another move in that direction.
Well, look, I'm not going to comment on cadre deployment because I'm not involved in politics and I never have been. And, I guess I'm as concerned about it as the next person in society. But I can talk about management. There are public sector facilities that are well managed, and there are some that are really poorly managed and have been poorly managed for a very long time. There have been studies done about why this happens. And there are no secrets about what the problems are. The problems is when there's political interference, you get bad management, not only because of cadre deployment, but because there's interference in the management of what goes on. So you may even get somebody who's deployed, if you like, who's fairly competent, who does a good job, and then there's interference in the way things happen. Then there's a change of politician and things change again. There's further interference. That's a challenge. We all know it's a challenge, and it's openly discussed in the public sector circles. It's hard to stop that from happening, that matter. Now, if one goes about the changes that are envisaged in the National Health Insurance Bill, and there are obviously those even in the public service who are opposed to the public service changes, but if one goes about it in the way in which it is designed, you will get greater autonomy at the point of managing the services. That's the one thing that needs to happen. But we also have a problem that, the physical environments of our facilities in some places are abysmal. But in those places, the budgets are not controlled by the health department. They are controlled by other departments, public works, sometimes premier's offices. Payments are not paid and choices are not made on which payments to make in the health departments in all instances. So it differs a bit from one province to the other. But this sort of spiraling down erosion of local responsibility for what happens in a facility has been going on for a long time. And it is something we have to stop. And we think that the plans that we are busy with at the moment, both in terms of the National Health Act, but also in terms of the changes that will come with the National Health Insurance, will make it a lot easier. I'm not suggesting this is going to be easy, and I'm not suggesting it'll have a short time frame. It's going to take time. But at least this will give us a framework that makes it more possible.
And the cost? We are, as a country, spending a lot of money on healthcare already, a big percentage of GDP. I think you yourself say it's somewhere north or almost into double figures. And are there any guarantees that we're going to be able to get better value for money as taxpayers? Or let's not say guarantees. Are you confident that we can get better value for money as taxpayers?
Yes, very much so. So, look, I think there are lots of elements of this. So let's start in the public service, because everyone always picks on the private sector when we talk about cost. In the public sector, we don't necessarily have the right balance of personnel. So we end up spending 70% and more in some hospitals on human resources payments. We have a situation where a large percentage of doctors, we're trying to work out how many there are, but also health professionals who we pay with our tax money never go to work. They go and work in the private sector, and you and I pay their salaries, and there's bad management of that time. So they call it RWAPs, or remunerative work outside the public service, and it's badly managed. If we just got those professionals to come back and work in the time that we paid them, and by the way, we also pay them overtime to go and work in the private sector. If we had managers who were able to control that, and it were uniformly controlled everywhere, you would get a lot more professionals at work. We also have nurses in particular who moonlight. It's a little bit differently structured from RWAPs, and that needs to be managed. We also have fraud and corruption, as you're aware. It's not as widespread as people say it is, but it's there, and it's extremely frustrating every time it's there. You get this punch in your gut and you think, yeah, not again, But we do need, as a collective, as a society, to deal with that fraud and corruption. We also have tender inefficiencies where we purchase things way more expensive than we should be paying for them. Sometimes those are on national tenders, but sometimes they are more local tenders with complicated purchasing procedures. So don't get me wrong, there are lots of ways in which the public sector could tighten their management and tighten the way that they spend money. But the challenges are also huge in the private sector. So we know that 15% of everything that is, and this is from the Health Market Inquiry, about 9% plus another 4 or 5% is spent in the administration of the money in the private sector. So when you purchase your medical scheme, before any clinician even looks at you in a rooms to administer their rooms, never mind to touch you as a patient, already 15% of your money has gone to the administration, either an administrator or to the administration of one of the 72 medical schemes. And that happens because of the complexity of 72 medical schemes with well over 200 different options, which you have to pick and choose from. And then you need to get a pre-authorization here, then you qualify, then you don't qualify, then they send something back. And that's all because they have to triangulate your particular, what you paid for against what your clinician is providing you with. And it's very complicated. So there's a huge cost in that. The second big cost is in duplication of care. So you'll be seen by one practitioner. When you move to the next place, that next practitioner has to start again. They don't necessarily have your lab tests, your x-ray results and everything else, especially if you're self-referred. And in that space, especially if you move medical aids, we have even had cases reported of someone who had a second appendicectomy done because the first one might have been legitimate, but the second one was collusion between practitioner, patient, and whoever else. So these things happen, and they cost the system. They cost the private system, they cost the public system. And then lastly, between the public and the private system, we don't have a portable health record. Whereas if you or I, or every other one of the 60 million people in the country had one health record that went and followed us around with our ID number, then we would be able to see that healthcare. We would not have to duplicate what is going on. We would be referred from one place to the other seamlessly. Now, that is something that we've been working on for some time. The private sector have been working on a separate one, and we have been working on one for the country. And we work together between their, what we call health information exchange, and ours in making sure that these systems will ultimately be completely interoperable. And we will get into a position where we can save a lot of money. Now, that amount of savings is huge. We believe that it could be as much as 50% of what is spent in the private sector, and probably as much as 5 to 7% in the public sector that could be saved for healthcare. But people want to add up. They want to take the cost of caring for a patient in the current fee-for-service system in the private sector and multiply it by 61 million instead of 9 million and say this thing's unaffordable. That's not how national health insurances work. You fix the envelope. So you may fix it at 5, 6, 7, 8, 9%, wherever your country feels it's affordable. So ours is at the moment, we spend about 8.5% of GDP. Countries who are our peers economically spend about 6% on healthcare. And countries that are bigger than us and have more clout, like the UK, spend about 12% of their GDP. So you have to take what you can manage to spend and then spend it wisely. And that's what needs to happen going into the future. Now, those changes do not happen overnight. You have to take them in bite-sized chunks systematically, but you must have a pathway. And that's what the National Health Insurance Bill tries to do. It creates a framework and says you now work towards that framework and introduce the appropriate regulations as you go. You give notice, you give periods of, in 12 months, we are going to introduce these benefits and pay for them from the fund. And at that point, you will have had to change the way in which your medical scheme funds the remainder of the package that you are not going to be insured for, and so forth. So there are many details like that people are just jumping the gun at the moment. We're nowhere near ready yet.
Nicholas, I think the big thing is, as a middle class, as a member of the middle class, am I going to be completely reliant on the public sector when I get sick, or can I buy insurance to take care of any medical issues that I might have. And I think that's the thing that is bugging most people in South Africa, where they look at the public sector and at some of the hospitals as they are now. And you've made a very strong argument for why we need massive reform of the sector. I think everyone has to get that after when you listen carefully to what you said. But does it mean, though, in the interim, in this time, that as a member of the middle class, you can still take out have your medical aid and still see a doctor quickly when you need it, as you would do, say, in the UK, where they have national health, but they also have private schemes?
So let's separate the purchasing and the providing of healthcare for now. Let's take me. I'm a middle-class South African who lives in a suburb, and I have two private, maybe three, but certainly two private hospitals within reasonable striking distance of where I live. And I have no public hospitals within 25 kilometers of where I live. I have a GP that I go to, and I don't have a full medical aid, so I pay out of pocket when I see my GP. I pay out of pocket when I go to the pharmacy, and I pay out of pocket when I go to the optometrist, and so on. That's my choice today. So now if I need care, I go to my GP. He's less than 2 kilometers from my home, and the GP needs to refer me for either an investigation or admission to a hospital for something. He will refer me to that nearest hospital to where I live. If they do not have a bed, he will go to the next nearest hospital. They both happen to be private hospitals, and if the condition is not cared for by those hospitals because it requires some fancy piece of equipment, whatever, then he must go and he must look for a place. Now, in my case, there's no public hospitals anywhere near where I live. There's no option for being referred to any of those. If I live in a township or in a place where there is a private hospital nearby, but there's also a big public hospital, I will either be referred to the public hospital or the private hospital, depending on who's the nearest, who's got the bed, who's able to provide that care at that time, arranged by my primary care provider. But if I'm living out in rural Sikisiki, there's no private hospital. You're going to go to the public hospital. That's where your first point of referral is. So I think it's very different from one place to the other. The challenge for us, of course, is for the person who lives at the moment, and the example I like to use is Diepsloot in Joburg. If you live in Diepsloot today, you have to go to Charlotte Maseche or to Tembisa Hospital. Those are your two referral hospitals. Very busy traffic, takes a long time to get there, and you drive past several private hospitals before you get there. For that person, the fund, not a medical scheme, the fund will have purchased my care in the first example. The fund will also purchase the care of the guy who needs healthcare in Diepsloot, but they will now send that person to the nearest hospital, which happens to be a private hospital. It's only 15 minutes drive now instead of 45 minutes to an hour's drive through the traffic into central Joburg. So I'm using these as examples to try and make it more personal and understandable. The point of it is, right now, talking about as an individual, if I need healthcare, I have to pay cash. So when I rock up for an investigation and they tell me 12,000 Rand up front, please, and I say, whoa, what do you want me to do? I'm going to sell my car or what? Now I get admitted to hospital in ICU, and my time is up and my provisions of my hospital plan no longer apply. Then what do? I find the money in my family and I'm put into financial hardship. And it happens all the time. With the NHI fund, the fund says you will pay nothing. You will not pay that 12,000 Rand upfront for that investigation. You will not pay anything at the point of care. The fund will pay. And it will pay the same amount because now there's one package, not 250 different options. And we will all know upfront, these are the benefits that are covered. And if I, as an individual, when I see that benefits package, whether it's in the first 5 years, the second 5 years, the third 5 years, as the package gets more established, if I see there are things that are not covered in the package that I would like to get healthcare for, then I go and I do complementary healthcare purchasing from the very medical aid that I used to use or not use in the past. And of course, what that means is that instead of having 72 medical aids going forward, we might end up with 5 or 6. And instead of having complicated administration, we will have very simple administration. So if your business is built on a business model of this complex administration, you are going to fight us in the media. And we accept that. Over time, they need to repurpose their business models, just like 25 years ago when they started and they had 50 or 60 staff instead of the thousands they have now. That's the nature of the world and of the business evolution.
Fascinating. Lovely to get the case for NHI. The process from here, presumably, we've heard from Solidarity's research unit, they are going to, have already said that they're going to take government to court on this. There will be others, no doubt, who will also be attempting. It could be a Stalingrad strategy from the private sector. How long do you think it's going to take to get to your preferred conclusion?
Yeah, well, it depends on what the cases are and how they are taken to court and so on. We fully expect to be taken to court, and obviously even before the bill was tabled in Cabinet, never mind Parliament, we already had a number of legal opinions and constitutional opinions. So we know where the touch points are. Quite right, Solidarity has a number of court cases with us at the moment. They the section 36 to 40 of the National Health Act rescission hearing was in our favor, and now we will defend on an even footing with them a case that was presented to the court without our participation. And we have no doubt they will take us to court on other things because they've already challenged the minister's right to have people doing the preparations for NHI. They never challenged my post or my appointment, but they challenged me having staff. So how they thought I was going to design the whole NHI on my own, I don't know. But the 44 posts that were created, funded to do the technical preparatory work in the National Department of Health, they objected to that. They lost their urgency case, and they will have to bring it, and we will defend it again. And I'm sure there will be other court cases. We've no doubt about that. And that's fine. So that's how democracy works. You raise your concerns, you raise it in Parliament. Parliament disagrees with you, agrees with somebody else. They go to the parliamentary vote, which has happened now. And it is through the Assembly, but not through the NCOP yet. That process will run until about October. Then it'll go to the vote again. Once it's in law, then, of course, people have got something to fight about. Right now, you can't argue about a bill. There's a parliamentary process for that, which the politicians manage. So we'll see how we go. And my job is to start building the administration to make this possible, to define what are these benefits, how will that benefit framework be, how will we make sure it's transparent and in the public space, how will the public engage with us on what we include in there, how will the board be appointed, not what's in the bill, but the technical details of exactly how the gazettes will work and be structured, et cetera, et cetera, et cetera. So that's what I'm busy with at the moment, so that when the bill is passed, we at least have a machinery to begin on the first part of the transitional provision.
Dr. Nicholas Crisp is the Deputy Director General of the Department of Health, and he's the man driving national health insurance, as you have heard. I'm Alec Hogg from BizNews.com.